Infectious diseases is one of the few genuine adventures left in the world, has said someone. According to the National Institute of Allergy and ID, emergent infectious diseases can be outbreaks of previously unknown diseases, as well as those that spread rapidly, or persistence of those that cannot be eradicated or dealt with clearly. To talk about this in detail, we have a world authority amongst us today. We are very thankful to her for flying all the way from Singapore, Professor Liu Yi Sin. She served as the Executive Director of Singapore National Center for ID from 2017 to 2023. During her tenure, she's established NCID as an innovative institution, integrating clinical care, public health, research, training, and community outreach. She's a recognized authority in her field, and she serves as a member in numerous committees and advisory boards, including multiple WHO organization work groups. She's received prestigious accolades and now contributes her expertise as senior consultant at the Director General Health Office in Ministry of Health, Singapore, and senior advisor, National Center for ID and National Healthcare Group. So without further ado, please welcome Professor Liu Yi Sin. Ma'am, please take up the stage.
Very good afternoon to all. I would like to give a great thank you to Somya and also PSIM for giving me this opportunity to be with you in Pakistan. And thank you for the very generous introduction. So I thought, when talking about infectious disease, perhaps I would just want to touch on emerging infection, because it is one of the key topics and key concern to the human health in today's practice, in today's medicine. So first of all, let me just introduce to you the definitions of emerging and re-emerging infections. Now this is taken from the National Institute of AIDS in the US. Outbreaks, basically we know that we are seeing something that is previously unknown and is challenging as emerging infectious diseases. But it can also be a known disease that rapidly increase in incidence in a geographic area in the last 2 decades. So in other words, it can be a brand new, novel pathogens, or it can be something that we knew about it and somehow make a return into that particular geographical locations. And for many of us, we also deal with many of the endemic and epidemic conditions where the disease may be persistent and it cannot be under control and it can return. So this is just to show you in a snapshot in terms of emerging infections, a very well-coded diagram and slides being used again and again to describe the significance of emerging infections and re-emerging infections. So this snapshot, you can see that no areas in the world, in fact, can be spared from emerging infections. And not only that, if you look at the red components of it in the year 2017, you can see there are so many new infections that cover the entire earth. So it certainly is not a topic that we can neglect in today's practice of medicines. So let's look at the time trend. Since 2003, that is the year we experienced SARS in many parts of the world, to last year, 2022, you can see that every year there will be some incidents happen in other parts of the world. And the red disease, coded in red, basically telling us those were the disease known to the humankind that have made a return to the new geographical area. And one of the things perhaps I want to specifically mention here will be the vector-borne conditions. Because of the global warming, we are now seeing dengue, we are now seeing chikungunya, we are now seeing Zika being reported in many parts of the world that never had such conditions before. Just last year alone, you can see there are so many new happening in the world. First of all is the first descriptions of Lanya, Hanipa virus that was described in China, basically involving the workers working in a cave that came into close contact with the bats. And this is a new virus that is being described in the year 2022. Is it really new? Likely not. Possibly the virus already in existence for over a period of time, but because of the newer technology, we are able to discover the new pathogens. Avian influenza certainly is threatening the world at this point in time, so you can see that the avian human influenzas that is being described in this part of the world, in Asia, in Southeast Asia, is now being reported in almost every part, especially in the Western world. Dengue continue to challenge us, and I think continue to challenge many parts of the world. Marburg virus outbreak has been described, and today there are still many countries reporting Mpox, which is previously known as monkeypox. So why is it so? Why is it so that in today's we are seeing so many emerging infections in such a high frequency? Possibly many, many reasons that have given rise to that. So first of all is human travel. We travel from one part of the world to another within a very short period of time. This diagram just shows you pre-COVID travel patterns. It basically covers all around the world. And in today, post-COVID, or rather post-pandemic of COVID, we are now seeing 90% returns of the travel pattern. So travel, in terms of humans, brings along with us many of the pathogens. The next thing is the megacities, and there are so many megacities in the world. Some part of the megacities, perhaps, is not being developed adequately to handle the sanitations and environmental factors, and that with the dense populations giving rise to a solid ground with the emerging infections. Now, one thing I want to also mention that yesterday we mentioned about One Health. I think Professor Akram mentioned about the One Health that he would love to talk about. And don't forget One Health, that is a critical component as the world that we look into emerging infections. As humans coming into closer intersections with wildlife, as well as the environment, and that give a perfect solid environment and solid ground for all this recurrence of the emerging infections. COVID-19 is nothing new to us now, we all know, and it caused millions of infections, and it has caused millions of deaths in the world. And no other countries, in fact, spared of COVID-19, and every region in the WHO is reporting cases of COVID-19. So you can see from the graph over here, and the sharp increase representing the huge outbreak in China. But we are fortunate that today, with availability of vaccines, the conditions are much better under control, where we still continue to see the existence of SARS-CoV-2, the etiologic agents of COVID-19. Now, this is part of the work that I will share with you. This is the Gate Ventures work that we work together with them, involving some of the collaborators from School of Public Health. And what we hope to do is to look at good examples in the world. And so we decided to have 6 countries from different regions that we perceive or we notice that they managed to control the situations of COVID-19 effectively. And we asked them, what would be the contributing factors towards their abilities to control the pandemic of COVID-19? So you can see from here, the number one things that is repeatedly being cited by these researchers from different parts of the world is a whole of government response with strong multi-sectorial collaborations and early establishments of national decision-making bodies, having a pre-pandemic preparedness plan. And number 2 is early effective outbreak control and case management to suppress COVID-19 transmissions and therefore minimize the essential health services. And that is critically important because when you have a novel pathogens where we do not know the full characteristics, it is important to have good control to allow us to understand the disease, phenotypes, and behavior. The third point was effective public-private partnership. We have to bring in all these partners to be able to work together and also emphasize on the strong academic government collaborations, because I think in a times of crisis it's important to bring in all the professionals to be able to assist the government, and what we need is to have evidence to be able to support the government's policies. And lastly, it is flexible health financing. I think that is critically important. In crisis, we need to have funding to be able to do a lot of research. We need to have funding to be able to mobilize some of the resources so that these resources can be utilized to be able to combat the outbreak, as well as maintaining the essential health services. And now that is critically important because We have seen so many of the countries dropping the immunization rate, increase the infant mortality rate, all because the essential health services is not able to cope as all the resources is being channeled to fight against COVID-19. This is just to show you in Singapore what we had, whole of government approach. We make an attempt to make it very early. So this government's task force was set up one day before the first case arrived in Singapore. And in addition to that, we managed to set up the research work group also one day before COVID-19 arrived in Singapore. And this task group effectively brings information to the entire populations on a daily basis or frequently as needed. I always share this with my healthcare workers. When we work in the field as a frontline, we want to have all this being provided for to us to be able to take care of the patients. We want to make sure that the personal protective equipment that we need to provide to the healthcare workers are there when they need it. Well, having said that, I think it's also important that the entire system must be able to support that objective. In other words, we need to have good logistics. We need to have all this needed material to be sent to the frontline people. We need to have movement of all these resources to be able to support the frontline. We need the supply chain to be very healthy. We need to have therapeutics. If the medications are needed, we must be able to mobilize and get all these medications. We need to have adequate equipment and ventilators. Now, all this may look very simple to the healthcare workers on the front line because we want it to be happened, but we need the entire systems to be able to support the functions of the healthcare system. Within the healthcare system, I just want to emphasize a few points. It is very important to have data capturing, data analysis, data sharing, and network. So in other words, information should flow from one area, one hospital to another hospital. Information should flow from Singapore to Pakistan or to somewhere else so that we can all learn about the conditions, about the disease together. Lastly, I just want to emphasize again that we have to really look into community mobilizations because I always believe that infections does not stop in just hospital. We have to involve primary care, we have to involve the community. Now, I just want to quote from the World Bank, looking at the current situations, because many of us are now very tempted to put COVID-19 pandemic behind us and moved on. But in actual fact, this is the right time for us to prepare for future public health crises. And we need the governments to focus on increasing the healthcare system's resilience. That includes strengthening prevention and responses capacities, improving our capability to respond, to be ready, and to be able to strengthen the primary care. So let me just quickly break it down into a few areas when we say that we would like to have a good prevention and strategies and also response. What would be the things that entail? So I think it's critically important for every country to relook into the pandemic preparedness framework. How can we sustain the public health system? How can we continue to have good surveillance because testing is really going down, people are testing less, and not only at the national level, but involving subnational, involving the community level. Do quick risk assessment, and sometimes we need to do rapid risk assessment, looking at the entire landscape of the emerging infections. Have adequate resources. A lot of commitments from the governments will be much needed to build up capacity, to strengthen the workforce, and improve the technologies and infrastructures to be able to cope with the future challenges. Central coordination, whole of government approach has been highlighted many, many times. It's important for us to identify the gaps, and I think it's time for us to look into after action review. Now, again, I want to take it out from the WHO's recommendation. Now, this is documents from WHO in terms of after action review. A lot of times we look into quite standard item. I just want to point out a few things that is in bold. A lot of the area that we identify and learn from COVID is something that we have to put it into our assessment. And that will include mental health. I think we mentioned quite a lot yesterday. We have to look into urban preparedness because of mega cities. There's a lot of crowding of populations, disease spread very quickly. How can we respond in the urban situations where there is mass gathering, where there's so huge number of people, and there's a good events, perfect events for the infectious disease to spread. I think lastly, it is something that is really critical important, which is the health system resilience. How can we continue to provide essential health services and yet be able to put into all these necessary items to get us prepared, ready to respond to the future outbreak? And I must say that there's a lot of challenges. Having said it is quite easy to say, but putting it together in action, it is not so simple, because in today's world, economic crisis, and there are many other needs that we have to look at, including concurrent health crisis. Many things that we have to handle all at once. It's not something very simple, but it's important for us to break it down into different items and emphasize a lot in terms of how we can utilize this roadmap from the WHO to reanalyze our situations and make our system better. So what we really hope not to see in the future is like that, where the infrastructure is not there to support our patients. There's no bed for them when they need it. There's no oxygens when they need it. There's not enough drips when they need it. And in a more sophisticated area, and perhaps, you have the ICU, but you may not have the skilled people, the ICU intensivists, to be able to take care of the patients. It may not have enough ventilators to support the patients. So those are the things that we have to think ahead, how to continue to build a healthcare resilience post-COVID, and what we can learn from COVID, so that this kind of human catastrophe will not have to happen again. Now, let me just quickly run through with you some of the critical components we are looking at. We need to prepare. In order for us to prepare, we must have a system to be able to detect, that is surveillance. And with the surveillance, we must be able to analyze, yes, no, to be able to respond adequately. And when we recover, we have to recover, learn from it, do AAR, and strengthen the system. So this is just to quickly mention to you that the WHO and World Bank together has established the pandemic fund. Very specifically for this round of grant call is to look at strengthening surveillance, and that will require strengthening laboratory. We need to improve our laboratory capacity to do the detections. And to have a good surveillance system and laboratory system, we really need human resources. Now, there are many types of surveillance that we can use, but the important thing is how can we bring all these things together to be able to increase our capacity and strengthen the entire system. Lastly, I just want to mention as well that the conventional kind of surveillance, we also learned that during COVID-19, we have to look beyond the conventional types of surveillance. Now, there are a lot of misinformations, and there's something that we have to deal with. We need to search for the social media, look at internet searches, and have the ability to understand what the ground is actually thinking and how the misinformations could actually affect good policies with evidence to be implemented. Now, coming back to One Health, this is a zoonotic spillover, and this is something that we need to pay attention to. 70% of novel outbreaks are caused by zoonotic pathogens, mostly viruses. So if we need to focus on this, I think it is important for us to understand human interactions with the animal, with the environment. And again, I think we need to focus a lot and be able to strengthen the virology. And with that understanding and the notions behind it, I'm sure many of you well informed that this is quadripartite, the MOU from the human health, from the animal health, from the environment, that need to come together to form the One Health approach, because we know that human, animal, environment all can be risk to our human health in terms of the emerging infections. So coming back to the surveillance, we don't only look into human, we have to now survey the environment that include vector, include many other animals, and also include even food and environment. And then wastewater testing is one of the tests that many countries are now looking into, using this as one of the technique in terms of surveillance of the environment. Now, I just want to also quickly mention to you again on the pandemic fund. And pandemic fund is specifically for the purpose to increase the capacity of the entire world. It's a global approach to level up the capacity to be able to have capacity building for different areas to be able to better respond to outbreak. So the first pandemic grant call has already concluded with 19 applications being awarded, and this system is now looking at future funding. So I think it will be very useful for some of our colleagues here to think through how to utilize the pandemic fund and how to apply for pandemic fund. Now, this is funding. This is not loan to you. This is recognizing the need that you need to do certain things, and you need to apply to WHO as well as World Bank through the pandemic fund to get the funding to be able to do the capacity building. Right. So having said that, I must say that in order for us to respond effectively to an outbreak, we must have a good assisting system that is flexible and with ability to search. So in other words, we have to continue to build the day-to-day healthcare system, and that will allow that systems to be able to respond to the outbreak challenges. And then I want to talk about, what commonly still challenging the world. I think polio has not been fully eradicated. Pakistan occasionally still report polio, which is a vaccine-preventable conditions, plus many other parts of the world. And this is something that I think we can look at in terms of how can we improve the day-to-day health system to make sure that vaccine-preventable conditions no longer exist. And some of the conditions that we want to see eradicated can be eradicated. Sadly, I must say that this is always on the front page on the WHO news. The returns of cholera. This is a 7th pandemic wave of cholera, where many countries in the world, over many regions, reported cholera. And in today, I think it is something that it is treatable, something that vaccine preventable, but yet we are seeing surges of cholera outbreak in many parts of the world. So now it's estimated that every year we have about 1.3 to 4 million cases of cholera cases, way beyond what we think it should have happened in today's, and about the case fatality of more than 1%. This is truly something, to me, unacceptable in today's practice, where vaccines available, where treatment available, where we can improve the infrastructures and sanitations, good clean water supply. Now, I just want to add on this point in terms of the cholera vaccine, because today there is a significant cholera vaccine shortage. Whatever the millions of doses being committed by the WHO for emergency search purposes is already all completed. So in other words, there is no more adequate supply of cholera vaccines to many of the affected area. So what have they done? They then recommend that instead of 2 doses of cholera vaccines, they are cutting it down to just 1 dose, just to preserve as much as possible. It will be short-lasting. It's not as good as 2 doses, but in such a crisis situations, these kind of drastic measures need to be done, which I think personally that this should not be the case for humanity. Dengue continue to come back. I think Soumya occasionally will drop me a notes on dengue in Pakistan and in many parts of the world as well. In Singapore, continue to see quite a fair bit of dengue cases as well. And avian influenza, you hear that almost very frequently. Many parts of different parts of the world, including Europe, including USA, they all reporting poultry cases of influenza and occasional transmissions to the humankind. Now, this is from WHO together with the Human Health, that they reported 67 countries in 5 continents just last year reported highly pathogenic avian influenza H5N1 in the poultry, in the bird system, in the livestock. And in addition, just this year, another 14 countries reported outbreaks, including America. So you can see that it is no longer a Southeast Asia issues where we see H5N1 avian influenza. Now it is many, many parts of the world, including the Western world. And not only that, 10 countries across 3 continents have reported outbreaks in mammals. So in other words, this avian influenza has now made a jump from not restricting themselves in just the poultry, now it's being jumped into many, many different mammal. At this point in time, the transmissions to human is still very limited, but we just don't know. And this is a report from China. They reported H3N5, another avian influenza, that has been already detected in many different kind of animals, including horses, dogs, seals, and of course in the birds. Now, what is more alarming is the report from China. They detected this virus in the year 2021, and they continue to study this virus, and they found that this virus in the laboratory system can infect human bronchial and lung epithelial cells. And not only that, when they do the human study, animal studies looking at the ferrets, they also demonstrated droplet transmissions, which is airborne transmissions. So now, of course, people are very worried about the avian influenza, at what point that it continued to jump species from the birds to different kind of mammals to the human, and whether or not one day it can become human-to-human transmissions. So I think we all have to bear in mind that although COVID-19 is kind of like in quiescent, but we will continue to be challenged by many emerging infectious diseases, and it's good to have us re-examine our system and look into the public health system, whole of government system, how can we address this issue so that we can be better prepared. So that was my last slide, and I just want to introduce to you the National Center for Infectious Disease in Singapore that was set up about 6 years ago, and I'm the inaugural executive director. We moved into this new building just barely about 3 years ago, and just barely half a year into after we moved in, we encountered COVID-19. So without all this faithful staff, very supporting staff, I think it's going to be very difficult. So again, I just want to emphasize on the human capital resource and human capital resource development. Thank you for your attention.
Thank you very much, ma'am, for a very enlightening talk. We're going to take questions, but in interest of time, just about 2 questions from the audience, please. Are there any questions for Professor Leo?
Leo,
okay. Mike, please.
We are already working on One Health initiative. In fact, in one of my universities where I was Vice Chancellor, we teach it as a subject, One Health. You know, we offer post-graduation in this, because that's, I think, in a country like Pakistan, it's extremely important. But what I notice, even in your slide, and even many others who are working with One Health concept, they don't add marine health, which is also integral part, because I believe human health cannot be looked at in isolation. Plant health, animal health, bird health, and then marine health, because they are all interconnected. So, and I think the global warming, the environment challenges that we are all facing, it's because of the lack of this concept or implementation of One Health. In fact, yesterday a presidential lecture was supposed to be on One Health, but since there is so much of dengue going on, I thought we will just do it, and maybe in our annual meeting now I'll talk about One Health. Another thing, I work with an organization that is ending the pandemics. You know, with COVID-19, I know my dear colleague, the Bhatt Sahab, is going to talk about it just in this session. But my point is that it's never been downgraded from pandemic to epidemic or endemic in any countries. Although it has decreased, but the WHO has not downgraded it. Still, because the threat perception is there, the threat alert is there. Right now, I'm working on a couple of studies right now, and a Paxlovid drug that is FDA approved. We are doing the trial in Pakistan right now. So we are seeing still cases. I don't know what's the Singapore situation like in there, and what sort of guidelines are you using? Are you giving antivirals? You are not giving antivirals? Isolating for a shorter time now, only 2-3 days, or what's happening? Thank you.
Yes, thanks. I think first of all, I'd like to congratulate your very forward thinking in terms of putting One Health as one of the key components, because I think it is critical in the understandings and preventions and and also readiness in the outbreak. So for COVID-19, the situation in Singapore, we now consider that as an endemic disease. So in other words, we accept that SARS-CoV-2 will exist and it will be in the environment, and therefore we label it or we treat it as an endemic conditions. With that in mind, we no longer specifically isolate anyone with infections. We will only bring people in that require medical treatment into the treatment facilities. Once they are in the treatment facilities, they will be isolated till the clinicians think they are no longer infectious. Then they can be in the general wards being mixed with the other people. Coming back to vaccine, our vaccination rate is more than 90% in terms of primary series vaccination. By now, I believe it will be 90% of the populations ever encounter or infected. So I think the hybrid immunity in Singapore, in fact, is relatively high. In terms of surveillance, we recognize that because it's being endemic, and that give rise to reductions in the testing. So people don't want to go for testing anymore. I think we have to recognize that that is one of the negative part in terms of surveillance. But we do have continuous surveillance in other area. We continue to have the integrations of the surveillance of acute respiratory infection. So in other words, things like influenza, RSV, COVID-19 are part of the surveillance in the acute respiratory infections. So routinely in our system, we will take samples from the primary care, from the hospital, to do the testing. So we know the test positive rate of all these pathogens to give us an idea. In addition to that, we also do the environmental screening. We have wastewater testing. So from there, we can also pick up the signal of COVID-19 plus many other pathogens that we have interest. Coming back to treatment, we use quite a lot, I would say. I hope we use more actually, because the medication is there, is available for free for patients with COVID-19. We use a lot of Paxlovid. We have molnupiravir, but the utilization is not as great because the clinical efficacy somehow is second to Paxlovid. And we use it for anyone 50 and above. And we use in patients with chronic medical condition. And we have evidence that it did reduce hospitalization, but the effect size is not big enough for us to make a definitive analysis decision that it cut down on mortality. So there's enough evidence for us to say that it will cut down on hospitalization. Okay.
I have one question. I just want your comments on two things. Dengue, is my favorite. One, what we were trying to build recommendations for point of care testing using the screening kits for testing of dengue. Previously, we use ELISA method for both NS1, IgM, and IgG, and sometimes PCR. So, what is your point on using this as the initial screening test for patients, the dual kits that are available? And secondly, we know that Zika and chikungunya, they are carried by the same vector, but we do not have much of chikungunya, very few cases, and Zika has not yet been reported from Pakistan. So do you recommend checking the sewage sample for these viruses for the early preparedness of any upcoming problems?
Yes, I think very good questions. So coming back to dengue diagnosis, our emphasis on dengue management is always early detection and early monitoring and close monitoring. And that has always been our treatment strategy. Early detection means that we try to have dengue diagnosed within 48 hours or as soon as possible, because once you hit 72 hours, you essentially may be entering into the critical phase, right? So what do we use? We use a lot of the NS1, IgM, IgG. So in other words, even in our laboratory system, we are using the rapid test kit to do the NS1, IgM, IgG testing. In DAP, we can do ELISA testing, which is ELISA testing for NS1. There's a little bit more sensitive. If not, we can always do PCR, because PCR ultimately is still more sensitive than the NS1. So for dengue, we rely a lot on community care, which is our primary health care. We have just rough about 10% of notified dengue cases require hospitalization. 90% are all in primary care. So educating primary care, make sure that they can deliver safe treatment is critically important. Now, coming back to the three pathogens, right? Zika, chikungunya, as well as dengue, a lot of overlapping clinical symptoms, and therefore it's very difficult to make a definitive clinical diagnosis, perhaps only until the convalescence state. Then you may be able to be more confident. And we want to diagnose it early, we have to test them, which is relying a lot on laboratory tests. At this point in time, not good enough of what is available to the clinicians. So what would be the ideal? My ideal that I hope to develop will be 3-in-1. So a test kit that can do performance to test all three, and to test for antigens rather than antibodies. So this is something they are working on to see whether we can use rapid molecular tests to be able to do all 3-in-1 testing. So it's still in the phase of development.
Do you do sewage sampling for dengue, chikungunya, and Zika?
Do I do
Sewage water.
sewage water? We can do that, but I do not think that at this point in time is being a routine things to do. For Zika, it really depends on how good the clinical case diagnosis. So our experience during this round, we realized that we captured the clinical cases before the sewage testing. So I would say that these two complementary. We cannot rely on just one for the other. We have to use both. Yeah.
My question is that most of the patients are asymptomatic, and we don't know if Zika is prevalent in Pakistan or not. So can we use sewage sampling to detect if Zika is present in this region?
Yes, you can. My answer very simple is yes, you can. Yes, you can. And for Zika, one good thing about Zika is that the antigen level is much higher in the urine, and therefore in your sewage system, it will be quite a good things to do. Whereas for dengue, it's less so. Yeah.
My question is that you were talking about the diagnosis of the dengue. As you were saying that it is the rapid test and there is an ELISA technology. And you know that immunochromatographic method which is used in the rapid diagnostic test is not a reliable test as compared to the ELISA. ELISA is the more sensitive than the rapid diagnostic test, and you know better than me because you are the expert of this diagnostic technology, that immunochromatographic method gives false positive and false result more as compared to the ELISA. You are ignoring those false negative tests who are actually suffering from the dengue, but when you are doing with rapid diagnostic test, it is generally it is negative. So these patients become more dangerous as compared to the false positive. Because in false positive, you have a patient may not have dengue, but result is positive. We can isolate, we can treat, and this patient is not dangerous as compared to the false negative. So why you suggest rapid diagnostic? Because in our Punjab, as far I'm Minister of Health of Primary and Secondary, we have given the order that we will not consider this immunochromatographic method. So what do you say about this? Should it is a good or as compared to the ELISA, or ELISA should be used as compared to the immunochromatographic method?
Sir, thank you very much. I think the question is again the same, that how reliable it is.
Not the same.
That how reliable it
It
is.
is not the same.
Right.
Question is quite different from that.
Please answer.
It really depends on the systems, right? So if your systems can give a very rapid diagnosis of reasonable good sensitivity, even PCR cannot give you 100% of the sensitivity, but it's the most sensitive one. If you can have a system to support you, then well and good, because you can utilize the system to be able to support that. For rapid tests, it is easy to use. It's lateral flow technique. And if you want to look into future, these are good things that you can even use in primary care, because you do not need the laboratory interface. And you can even do a home test. You know, this is something that we are moving towards, more of the community involvement in many of all these rapid testing modality. So it really depends a lot on your system. If your system is so good that you can turn around PCR, then why not? But PCR by itself is a technique that, you know, you need laboratory, and the turnaround time is not as fast as the antigen testing of the lateral flow that we are using currently. So I think it is really depending on what you want to use that is best suited in your system, and what is most good and cost effective. Yeah.
Thank you very much, ma'am. Please have a seat. This has been a very